Good. So it says that behavioral support units should be created as a regional resource. Now, just noting here that the recommendation is to create them, I know that not everyone agrees that we should have units like this. So we should probably, in our discussion, really go back to basics and really discuss, is this a good strategy when we're looking at the system as a whole? But again, going back to that pyramid, I would suggest that there are some individuals who could benefit from specialized units, at least for a period of time. There are recommendations about staffing ratios of regulated to unregulated staff, suggesting that they should range from 40-60 or 50-50 rather than the current, which is 20-80 or even less. That staffing levels of allied health professionals be increased to include a range of providers of different disciplines, and in particular, regular access to a pharmacist is critical because drug issues are important. That the units have a maximum of 15 to 20 residents. They should support, really, there should be resident choice. It actually says patient choice in the document. I think they meant resident choice. The unit should be affiliated with a long-term care home or another facility. The admissions should be managed by the CCACs in cooperation with a psychogeriatric outreach team. That there should be regular priority reviews of both admissions and discharges, and in order to prevent blocking the bed so that you could end up with a group that there's not much turnover in the units, but highly specified and specific admission and discharge criteria. The residents should be transferred to a long-term care setting. Being transferred to a long-term care setting should have assistance from the psychogeriatric outreach team and special funding to follow that resident, because it's clear that they may need extra staffing for a period of time. That these units should be funded from outside of the current resident classification system and based on 100% capacity, not a per diem rate. That referrals to the psychogeriatric outreach team should be mandatory if a resident has the potential for aggression. And so then I wanted to turn your attention to the issue of evidence. So is there evidence in support of the benefits of such units? The literature usually calls them special care units rather than behavioral support units, but they're pretty much the same thing. And so Cochrane reviews are really the, as you know, are special reviews that are carried out by individuals who really go through the literature very, very carefully using very specific criteria, and they tend to be tough. They tend to take a very, very scientific approach to the evidence, and they exclude studies that do not use rigorous approaches. So this is from a group from Hong Kong, actually a group of nursing group from Hong Kong who decided to do a Cochrane review on this topic. So are special care units better for individuals with behavioral problems, was their question. First point is there's no randomized controlled trials at all. There were 4 studies available with extractable data. And the study suggested a small improvement in NPI scores favoring special care units and less use of physical restraints. That's these non-randomized trials. And the NPI is a neuropsychiatric inventory, which is a measure of different neuropsychiatric symptoms. The authors actually concluded that there is no strong evidence of the benefit from a special care unit and suggest that the most important thing is the implementation of best practices. So it takes us back to basics. I'll mention a couple of recent studies. These are comparing individuals in special care units versus traditional care. This is a German study. They compared 594 residents in special care units to 573 residents receiving usual care. They did control for a variety of confounding variables. And they found that in special care units there was more social contact to staff, which is an interesting phrase, more involvement in activities, more volunteer involvement, fewer physical restraints, more use of psychiatrists. I don't know if that's a good thing. And but I can say that I'm a psychiatrist. So. Less use of antipsychotics, which is good as far as we know generally, and more use of antidepressants. So they shifted their overall use of psychotropics was about the same, but they were using much more antidepressants than antipsychotics. So it looks like these would be a trend certainly towards what we would consider better care. And then another study here from Italy also similar approach, although this was not a cross-section, it was actually a longitudinal study. And so the residents admitted to special care units here were younger, less impaired cognitively and functionally, but had more behavioral problems. And over 18 months, the special care unit residents had less hospitalization, less use of physical restraints, and a higher rate of withdrawal from antipsychotics. So again, some similar findings. So I'm just going to check on the time. How much time do I have? Oh, good. 7 minutes. Excellent. Okay, so this comes from the recommendations from the Canadian guidelines around managing behavioral symptoms. And in this section, there are a lot of recommendations about non-pharmacological interventions, which should come first. So, and they're grouped together as social contact interventions, sensory relaxation interventions, structured activities, and individualized behavior therapies. So here are some of those kinds of interventions. And they range from many different approaches, including things like pet therapy, which we all know is a good thing. And there's a lot of literature now, growing literature really on non-pharmacological psychosocial interventions. This is one review from Livingston from the American Journal of Psychiatry, another review by Clive Ballard from England, and another here from Karen Kverno. So each of these reviews is slightly different. And there's also a review in the recent edition of International Psychogeriatrics. But by and large, they tend to suggest that there is evidence in support of a lot of these interventions. But there are different types of approaches in terms of design of the research studies. So very few of these studies would take a group of very severely agitated or aggressive individuals and then do a randomized controlled trial. They tend to be more, let's try this intervention and follow them over time and see if the symptoms improve, which is a very different approach. But by and large, a lot of these interventions do seem to show definite benefits. A behavioral management approach described by my colleague Dmitro Revelak includes a careful cognitive assessment, then a behavioral assessment, but then including in looking at staff perceptions about the behavior, very critically important. And then in this approach, they use behavioral techniques and what Dmitro calls staff stress inoculation, which is actually helping the staff deal with their stress associated with dealing with these very challenging behaviors. So it's a very comprehensive approach. And this is the ABC approach. This is from Australia, this graph, but it's really looking at the consequences of the behavior. And then, like this, they've added a D, which is to decide and debrief after you've done an ABC analysis. My colleague Ken Schwartz has written about group psychotherapy for nursing home residents, not something that would jump to your mind probably, but he's been doing this work and finding it beneficial. It tends to be for the individuals with obviously mild to moderate impairment rather than severe impairment. But he's written about this in the International Journal of Group Psychotherapy. And this is actually a group at the old Spiders home. I'm not going to say much more about drug use, except to say that we have to be extremely cautious and careful about how we use psychotropic medications. There's been a huge amount written about this. Actually, the IPA is just putting out a new version of its education pack on behavior, on BPSD, and Dallas actually was involved in looking at the psychopharmacology, the latest evidence in support of this, but that'll be available from IPA soon. But looking at the